Thank you, Mr. Chairman. Assalamu alaikum. It's my pleasure to talk in the Congress. Now, my task is to talk about the future of Ramadan risk calculation, as I think in light of many of the researches, although I did not hear many of the projects before. So I will tell you my view on that. I will talk a little about Ramadan risk calculation. I will talk about advantages and limitations. I will review few studies. Then I will talk about emerging issues in the risk calculation. I will talk about pregnancy, CGM, closed loop insulin pumps, frailty and cognitive function, home support, regional variation, and some other that I did not have the time to do so because the time would not allow any of that. Then I will talk a few words about the future. Now, as you know, 3 years ago, this tool was introduced to calculate the risk of patients during Ramadan fasting. And you could see 14 elements. Each one of them has a specific score. And when you add them up, you will get a risk score, a risk level, medical recommendations, and also religious recommendations. Now, the goals for risk calculation was to unify fasting assessment, to incorporate medical evidence into the equation, to quantify potential risk effectively, and to offer calculated personalized risk reduction for patients. Now, advantages are clear. It assures the best outcome for our patients. It motivates patients. It supports physicians in their decision-making. It bridges between medical and religious recommendations, and that was a huge problem in the past. And it optimizes resources allocation when you have a busy clinic and so on. Now, there are so many studies, and we heard about many more new studies about risk score validation, exploring new risk factors, as we heard, retinopathy, neuropathy, and so many others, and risk score reduction. I have a few of them here. Now, since the use of the risk calculator, it became actually a guiding, pivotal tool to guide physicians, at least in our service and in many other services, that we started depending on this tool to evaluate all our patients. However, this tool is not without errors. It relies on limited data, and now you could see that we're getting more data, more very relevant data that we probably missed in the past. It overlooks very important factors. It lacks the consensus on many occasions. Many experts in the field are challenging the calculator, and that's okay. The risk factors are actually dynamic, and you could see that we have new medications, we have new monitors, we have new devices, and all of that will have to make us rethink many factors and the calculation. So the way I thought about this, the first factor, the emergent issue, is pregnancy, and according to 2021 DaR recommendations, we were clear in saying that safety of fasting in pregnancy is not certain, and we advised all women, all pregnant women, not to fast. However, probably having this in the risk score misled many people. We know, all of us, we know that there are so many potential risks to pregnant women and to their fetuses, including dehydration, nutritional deficiencies, stress to the fetus, potential macrosomia, non-compliance during, and we reported that, non-compliance of glucose monitoring, increased risk of hypo and hyperglycemia, even if they were on diet alone. And we have no idea, nobody has any idea about the long-term effects on the offspring. Now, what I suggest, again, safety of fasting is not certain, again, the same recommendation, and we have to avoid potential risk for both the mother and offspring, and all pregnant women should be advised not to fast. In addition to that, I would suggest that this probably it's very important to exclude pregnancy from the risk calculator, not to confuse anybody anymore. Now I'll move to continuous glucose monitoring. We heard a few presentations on that, very interesting, ones on insulin pumps and the CGM. Now in the risk calculator also, there was mention of SMBG. We did not mention continuous glucose monitoring. And as you know, the more patients check their sugar, we gave them a lower score. But we attached that into the hypoglycemia incidence. So if they have more hypoglycemia, then they have a higher risk, and consequently they're evaluated and ranked as high risk. Now, as you know, advantages of CGM are really, confirmed. They have real-time monitoring with alerts. They can early detect hypoglycemia. They have the data trend and patterns, so you know how to really modify. They reduce the need for finger stick, which makes it really easy for patients and more convenient. And it improves the quality of life for people when they fast Ramadan. It has personalized insights, and you could even monitor from far away. So this makes it easy for people to fast during Ramadan with less incidence of hypoglycemia and so on. My suggestion that we still need more studies, although we heard a few studies today, very good studies. We would suggest that we add a negative factor for people who are using CGM. So if the score is high, but they're using CGM, the score will go lower, and probably that will give them a different level of risk from probably high to moderate or moderate to low risk. And that will actually give incentives to providers and patients to use these devices. I'll move to the closed loop insulin pumps, and also we heard a few presentations on that, and in our considerations, we did not consider the closed loop insulin pumps, and we gave 2.5 for insulin pumps. It looks clearly from new studies from many institutions, including ours, that 2.5 probably is high. And again, we know the advantages of closed loop. So what I would suggest that we need more research, and we are getting some. And again, a negative factor is suggested to be added to this. And that probably will, again, give a good incentive to providers to use these technologies. I know they're expensive and so on, but we're talking about people who are using them. I'll move to frailty and cognitive dysfunction. Now, in the risk calculator, frailty or impaired cognitive function was classified as high risk for patients. People who had no home support were classified as moderate risk for fasting. And as you know, frailty is not only about physical or cognitive, but also it could be psychological, and it does clearly impact susceptibility to adverse events during and quality of life during fasting. Now, in this study, not published yet, by Dr. Latif Al-Kitbi, Dr. Hassaneh was a part of it also. We had a group of elderly patients, 2 or 4 patients, and their evaluation showed that 9.8% of them was frail, 43% were pre-frail, and 46.6% were robust. Now, not surprisingly, we found that patients who were robust, they had less complications during fasting, and pre-frail had more complications, more Ramadan event rate, and the frail patients had the highest rate of complications. Now, only 25%, and this is probably very important, only 25% who were classified or identified as frail patients on the frail assessment tool, which is a known tool that is used by internists and so on, only 25% of them were classified by physician on the risk calculator subjectively that they have if they're frail. And you could imagine that the difference between structured and objective evaluation and clinical judgment are big difference. I mean, the frailty tool is clearly objective, standardized, consistent, reliable, validated. However, it's time-consuming and less practical when you compare to the clinical judgment. In 1 second, you say this patient is frail or not frail. Now, the study conclusions, the study that is not published yet, again, it underscores the significance of frailty assessment when assessing the risk of fasting during Ramadan. The disparity between subjective and objective assessment emphasizes the need for standardized evaluation method, and using the frail tool is one of them, is recommended. Now, suggestion for this item, probably we have to implement a brief validated frailty tool. The frail is one of them. We should probably consider frail status as a moderate risk. We should consider adding new factors to the calculator, like fatigue, ambulation, capacity, physical activity, in order to verify whether these patients are frail or not frail. And probably easily we could now integrate these tools in our electronic systems. We should provide training for healthcare providers to do so. Maybe we should consider referring to other specialties to evaluate our patients. And if it is very busy for us, then we should consider our high-risk patients. Home support is a very important item. And according to the same study, not all patients who are elderly are necessarily frail, only 9.8% of them. So I would say not all elderly patients require home support. More research is still needed. Keep same recommendations, however, consider adding pre-frail as a moderate risk. Now, other emerging issues, regional variation. Now, according to the non-fasting population, we had 18% rate of non-fasting, and you could imagine that these are the same high-risk factors that you could think of. But it was surprising that there's a huge variation. In Turkey, 56% did not they choose not to fast. However, in Malaysia, it was only 1%. And this is a huge difference. It could be related to many factors, maybe religious practices, could be cultural, could be economic, education, awareness, knowledge, and access to guidelines by physicians. Prevalence of diabetes might be an issue, climate, and seasonal variation. We should try to bridge between the regional variation, probably by educating health providers, engage local communities, share experiences, and do more research and collaborate all of us together. Now, other factors, many factors, we heard about them today. Now, we should consider the post-bariatric surgery patients. We have so many of them, not sure how to do. Many of them have complications during Ramadan, and we need to address this. We have the patients who have multiple complications, stable complications. Would stable complications make patients high risk, or will keep them as moderate risk? Also, many medications now, we have the premixed insulin story we heard about, we have the new combinations, and so on. We need to address all these factors. The new risk, the future of the diabetes and Ramadan risk calculator, probably we should modify some of the existing scores and factors. We need to add new potential factors, as we heard. We need to personalize the need for our patients. We have to integrate CGM devices and the mobile apps. We need to consider ethical, cultural, and other variations. We need to educate patients more, and real education, and empower them. We need to collaborate with each other, which we're doing, and we need to validate the tool continuously. My take-home message is risk calculator is very valuable for decision-making and risk mitigation. Risk evaluation and reduction is a continuous process, and we must reassess the model continuously in order to keep it updated. Thank you very much.